basically, the heart rate is generally an important parameter in overall body function, and it plays a key role in determining cardiac output. We all know that cardiac output is heart rate times stroke volume, and that same cardiac output times the mean arterial pressure gives us total peripheral resistance gives us the blood pressure. So then heart rate feeds into both the cardiac output formula and the blood pressure formula. And heart rate abnormalities are an important cause of various symptoms. So when you have brain hypoperfusion, there's dizziness and syncope. You have coronary hypoperfusion, you can have ischemic chest pain. Peripheral muscular hypoperfusion, you can have easy fatigue. And the cardiac conduction system invariably determines the heart rate. So if it's not too efficient, then your heart rate is lower than it should be. Um, so just as an overview, and I'm sure we all know this. So the SA is in the high right atrium, the posterior superior wall of the right atrium. It's depolarizes spontaneously, sends impulses via Bachmann's bundle to the left atrium, and the internodal tracts depolarize the right atrium. Then the impulse moves to the AV node where there's a physiological delay to allow the ventricle fill with the blood that has been pumped in the atrial systole. Then it goes to the bundle of His down to the right bundle and left bundle, and then to the Purkinje fibers. This just shows the perfusion of the conduction system. I'm not really going to spend much time on this. And then I believe, so there's a prototype ECG. I believe we all know what the intervals stand for generally. So P wave is atrial depolarization. PR interval is from depolarization of the atrium to depolarization of the ventricle. It encompasses everything from the conduction down the internodal fibers into the AV node, down the His until it reaches the Purkinje fibers where it stimulates depolarization of the ventricle. And then the ST segment has to do with the repolarization of the ventricle. So let's look a bit more at a few more specifics of the bradycardia. So generally, we say sound in bradycardia when there's a heart rate of less than 60 beats per minute. But in clinical practice, we usually give an allowance up to 50 beats per minute because physiologically, it rarely has consequence if the heart rate is between 50 and 60. And the bradycardias are generally either from an SA nodal dysfunction or an AV nodal dysfunction. SA nodal dysfunction is a bit more difficult to pick on the surface ECG, but then AV nodal dysfunction is what we tend to see all the time. A lot of us know about tachybrady syndrome, but SA nodal dysfunction is bigger than tachybrady syndrome, and it's basically arises either due to problems in generating the pacemaker action potential or transmission out of the SA node to the cardiac tissues for them to be polarized. And so there are various types: the sinus bradycardia, the popular tachybrady syndrome, sinus pauses, sinus arrests, sinus exit blocks, and then contractile incompetence. Sinus pauses, probably you'd classify sinus arrest and sinus exit block as sinus pauses. But the main difference between the exit blocks and the arrest is that with the sinus exit block, the current is the action potential is generated, it just doesn't come out. The next one may come out. So usually the RR interval where you have the exit block is a multiple of the prevailing RR pattern. Whereas for sinus arrest, the SA node just freezes, it stops working, and then it restarts working at another point in time. So then the RR interval after the arrest may not necessarily be a regular multiple of the prevailing RR interval. So as I mentioned, sinus bradycardia, we accept up to 50, but strictly speaking, it's less than 60. Sinus pauses basically mean that there's a wide RR interval without any intervening ventricular depolarization, which suggests that the ventricle or there's no contraction, or there's no depolarization within that time. Normally, if it's current guidelines suggest that for a pause to be significant, it should be more than 6 seconds. However, if it's more than 3 seconds and the person is symptomatic, then it is significant. Um, and we've talked about sinus arrest. The tachycardia syndrome, patients have a baseline bradycardia with paroxysms of supraventricular tachycardia, with AFib being the commonest one that occurs. Then, to the AV nodal blocks, we have the 3 degrees, which we all know about: first, second, and third. First degree is actually not a block, so some will say it's a misnomer. Basically, there's just a delay in the conduction, so the PR interval is prolonged. In second degree, there are 2 types: Mobitz 1, Mobitz 2. Mobitz 1 is also called the wave feedback, where you have a progressive prolongation of the PR interval. And then eventually there's a drop, and then the cycle starts again. With Mobitz 2, you have a fixed ratio, so you have a fixed block. For example, a 2:1 block. PR interval is equal throughout. So patients with bradycardia, you have a fixed ratio of P waves to QRSs. And then complete AV block, where there's AV dissociation. PP intervals are normal, R are equal, RR intervals are equal, but there's no communication between the P's and the QRSs. Now, the blocks in conduction can occur at various levels. So it can occur within the AV node, which is typically what we see in the first degree AV blocks. And it could be infranodal. And infranodally, it can be within the His bundle or within the bundle branches. And the lower the block, the less stable the rhythm and the greater the need for intervention. Similarly, the lower the block, the when you have such blocks, you have escape rhythms, and the lower the escape rhythms, the broader the QRS complex. So really, the PR interval is more or less a composite figure, which represents the entire conduction from AV node all the way down to the ventricle. So having a prolonged PR does not necessarily mean that it's an AV nodal block. And in fact, there are cases of first degree AV block that are due to conduction delays at the level of the His. And those ones are more severe than those that occur at the level of the AV node. And an EP study where you measure the A to H and H to V intervals will give you a much better appreciation of where the block is and what treatment is. So in this ECG, you see clearly there's the P wave and there's quite a broad PR interval. It's about 2 big boxes plus maybe another 2 small boxes. So let's have about 10 small boxes. So this is a first degree AV block. You realize that you have that prolongation all the way through the strip. Now in this one, when you look at it, first of all, you realize that there's what we call group beating. So you have 4 in a group, and then there's a gap. You have another 4 in a group, and then there's a gap. Once there's group beating, your first suspicion should be a Wenke bar. Then you look at the PR intervals, you realize that here, this is shorter than this, a little shorter, or maybe almost the same as this, and this is longer. And then you have the drop. But the trick with the Wenke bars is that when it's suspected, just look at the PR interval after the drop and the PR interval before the drop. Once the PR interval before the drop is longer than the PR interval after the drop, it invariably confirms that it's a Wenke bar. And then here we have a fixed 2:1. So you see 2 P waves QRST, 2 P waves QRST, 2 P waves QRST. This is the classical 2:1 AV block. And then here we have third degree AV block where there's AV dissociation. AV dissociation basically means that P waves occur within the QRST complex, which is not supposed to happen. So you have a P here, you realize that here the P is within the QRS. Then you have another P here. Here it's still within the QRS. By this point, it's come out. But you realize that this P is now almost within the T. Here it's in the T. So you realize that there's really no relationship between the two. and this is classical complete heart block. Um, Causes may be degenerative conduction system disease, which is primary, or it may be secondary. So anytime you have these heart blocks, you need to investigate, see if it's secondary. If it's secondary and you can correct something, you correct it, and then observe if the heart block does not um, correct to normal, then you can go ahead and then act further on it. Um, as a general rule of thumb, once the patient has a symptomatic bradycardia that is not amenable to any therapy, then the person is a candidate for pacemaker therapy. So generally, if there's symptomatic sinus node dysfunction, there are infranodal AV blocks, especially the infrahis AV blocks, which tend to occur in the second degree, morbus 2, and then the third degree AV blocks. Then you consider pacing, as well as symptomatic AV blocks, even if it's not infranodal. So you can even have a third degree AV block, which is really prolonged more than 300 milliseconds, which may be in close approximation with the T wave. That can mimic pacemaker syndrome, and so you may need to pace that patient because of the symptoms the patient has. But then for the intranodal rhythms that are asymptomatic, you just observe. If they're symptomatic, you go ahead and then pace. So now we come to the main subject for this presentation, which is the pacemakers. So pacemakers are made of the pulse generator and the leads. The leads are just the channel through which the pulse generator communicates with the heart chambers. And the pulse generator is made of a battery, a circuit board, and a header. This shows a bit better. So down here,
Hello, Dr. Sama, we can't hear you. Or is it only me? Can anyone hear the sound?
No.
Dr. Sama, please, we can check your sound. Hello, Dr. Sama. Dr. Sama, we can't hear you.
Dr. Conte, I think you should log him out so he will log in again.
Yeah, I'm calling him on the phone so that I can sort it.
It's all right.
Hello, Dr. Samuel, can you get me? Hello.
He's not connected with his audio. That's one of the challenge. I can see his network.
Sorry,
He's
can
trying to
you
connect
hear
with his audio. Okay, all right, good. It's now.
Yeah, I can hear you now.
me?
We lost you from the point where you start talking about the structure of the pacemaker. And I've been trying to go back to where you started talking about the structure of the pacemaker. That's why we lost you.
Chief Conte, his audio is not connected. If you go through
Can
the
you hear me?
list.
Yes, Asama, I can hear you now.
Okay, sorry. I think I had some network issues. So where did you lose me?
From the point where you started talking about the structure of the pacemaker.
Hello, can you hear me?
Yes, we can hear you.
Okay, so sorry, where did you lose me?
The point where you start talking about the structure of the pacemaker.
Oh, okay.
Yeah.
That's quite so here.
Yes, yeah.
Okay. So I was mentioning that the pacemaker, yeah. Can you still hear me? Can you still hear me?
It's breaking a bit, but we can hear you. Go ahead.
Okay. Yes, so I was explaining that the pacemaker is made of parts. We have the battery, which is here. Then we have the circuit board, which is where all the electrical activity takes place. So this is where you have, and then this connects to the header, which is where you have the atrial and or ventricular leads to conduct whatever pacemaker activity is going on to the ventricle. All right. So then there are three types of pacemakers. We have the single chamber pacemaker, which is over here. As you can see, it has one lead here. We have the leadless pacemaker, which is the small one here. And then we have the dual chamber pacemaker, which is over here. And we have two leads, which show that it's a dual chamber pacemaker. So the leads go into two different chambers. And so, can you please confirm that you still hear me?
Yeah, we can hear you clearly. Go ahead.
Okay, all right, thank you. So there are certain things that we need to understand because they are an important component of pacemaker lingo. And anytime people are discussing pacemaker related issues, these terms will be flying all over the place. So first is sensing. And one type of sensing is the ability of the pacemaker to perceive intrinsic cardiac electrical activity. So it's able to pick up what's going on in the atrium, whether it's by the sinus node or down in the ventricles. It's able to pick it, and that's called sensing. Now there are times that the pacemaker will, it's all electrical activity. And so there are times that other electrical activities will confuse the pacemaker, and so the pacemaker will pick those up. That's what we refer to as oversensing. So it may be picking things that are not actually cardiac activity as cardiac activity. For example, muscle contractions and diaphragmatic movement, etc. Then we also have a phenomenon called undersensing, where cardiac activity is ongoing, but the pacemaker cannot see this cardiac activity. This is what we call undersensing. We'll look at the implications of over and undersensing as the presentation goes on. Then we have impedance, which is also called resistance and refers to the sum of forces that oppose flow, that oppose the flow of charge or flow of current through the pacemaker system. Now, when we talk of pacemaker capture, what we mean is the ability of the pacemaker to deliver enough energy to consistently depolarize the myocardial cells. And so this consistent depolarization will result in a pacemaker spike and activity. The threshold refers to the minimum energy that is required to capture. So then, for example, if all you need is 2 millivolts, to 2 millivolts of 2 volts per millisecond to capture the ventricle, you may still be able to get that capture when you are doing 8 volts per millisecond. But the threshold, which is the point at which capture begins, is what we call the threshold, the point at which the capture begins. That's the minimum energy. And then there are two other important terms. When we talk of inhibition in terms of pacemakers, then we mean that when the pacemaker senses intrinsic activity, it withholds its activity. It doesn't discharge any current because it has picked something up. So that is inhibition. And then similarly, to trigger means it has seen something and therefore it is starting its activity. So these are just a few terms that we'll need to know. So there is it's called the NBG code, the NBG pacemaker code. And usually we tend to use the first 3 positions. So we've heard of VVI, DDB, VO, etc. So the first letter refers to the chamber that is being paced. So if you are not pacing any, then it's O. If you're pacing the atrium, it's A, ventricle V. And then if you're pacing both atrium and ventricle, then it's dual, so D. Then second is the chamber being sensed. And then the third is what the response is to sensing. When you sense, do you trigger, do you inhibit, or you do both? Then there's a position 4 that is sometimes you start the rate modulation. So single chamber pacemakers, as I mentioned, you have a single lead, which is either in the atrium or in the ventricle. So it paces and then senses the chamber in which it is implanted. It's a much simpler procedure because they're putting just one lead in. But because only one lead, it is not exactly physiological because it is only doing things based on one chamber. It is not looking at any of the other chambers. So when we take single chamber pacing, then we have these modes: AAI, which means you're pacing the atrium, sensing the atrium, and when you sense, you inhibit. If you don't sense, you end up pacing. VVI, you pace the ventricle, sense the ventricle. If you sense ventricle activity, you inhibit. So you hold pacemaker charge. Here, you pace the atrium, you're not sensing anything. So if you're not sensing anything, then definitely there's no response to sensing. So what this means is you are just pacing the atrium at the given rate. It doesn't matter what's going on in the atrium. Similarly here, VOO, you're pacing the ventricle. You're not watching anything else. You're not watching any chamber. So then whatever is going on, it doesn't matter. You are just pacing. Then and when you sense, it triggers pacing. And then VVT, pace ventricle, sense ventricle. When you sense, it triggers. Clinical uses of atrium only pacing. So if you have a sinus node dysfunction and the conduction system is intact, and in your clinical estimation you don't anticipate further degeneration, then you could do atrial only pacing. So hypothetically, you have a young person who, for some reason, has some symptomatic bradycardia, has no cardiovascular risk factors, and the only problem is the bradycardia. And you don't anticipate any further disease going down. You could do atrium only pacing. Then you would want to do atrium only pacing when you're going to do surgery that requires cautery, because the electrical signal from the electrocautery can be picked as electrical activities and can trigger a response from the pacemaker. So that one, you tend to the AOO, which is also called asynchronous atrial pacing. So in that case, you're going to do the procedure. I don't want it to interfere with the timing. So then you just set it to pace the atrium at certain regular intervals. Similarly, when there's going to be exposure to electromagnetic interference, like you're going to an MRI, or as a bridge to definitive therapy after lead failure, you can do AOO. One way you can easily do AO is just to put a magnet on top of the pacemaker and it automatically switches to AO as long as the magnet is there. Once the magnet is taken off, then it goes back to whatever mode you had it in already. Ventricle only pacing, you can have that in third degree AV block with AFib, and this is usually done when you have AFib where you're having difficulties controlling the rate, patients are symptomatic. So you ablate the AV node so that now no impulses come from the atrium down into the ventricle. And you put in a ventricular lead and then do a VVI pacing, which is just a purely ventricular pacing. And then you can also do that for higher degree AV blocks with a normal functioning SA node. But you will realize that when you are pacing just the ventricle, at times you may end up having a situation where the ventricular contraction may coincide with a T wave. And so in the end, it would sort of, the ventricle is not relaxed to receive the blood from the atrium. And so it sort of bounces back into the atrium. You may have like a cannon A wave kind of thing. And this thing can cause significant hemodynamic issues, because at that point, then you'd have, at that instance, you have a low cardiac output, brain can get hypoperfused, you can have a syncopal event. Tachybrady syndrome with AFib, the explanation is pretty much the same as third degree AV block with AFib. And then again, surgery electromagnetic interference, those ones you do VO, which is ventricular only pacing or asynchronous ventricular pacing. Now, we have a more physiological method, which is the dual chamber pacing. And what this one does is that it allows the atrium and the ventricle to communicate. Now, this mimics what happens in real life, where you have the atrium contracting while the ventricle is relaxed. It waits a bit, the ventricle fills up before it contracts, atrium fills up, that kind of thing. So it's a more physiological mode of pacing. And just that because you're putting in two leads, then it's a more complicated procedure. Yes, but then it's more physiological. So pretty much dual chamber pacing, it's generally more preferred. You can use it for higher degree AV blocks, you can use it for sinus node dysfunction, where you expect progression of conduction system disease, so that atrium and ventricle are communicating. And then we have DOO, which is also asynchronous dual chamber pacing, which will have the same indications as the AOO and the VOO. The commonest dual chamber mode is DDD, where both chambers are paced, sensed, and when they're sensing, they're both inhibition and triggering. We'll look at that a little later. So this just summarizes some of the situations which you'll use the various pacemakers. And you realize that for all of them, first choice is dual chamber pacing, except for where there's AFib. That's the only one that has VVI, which is ventricle only pacing. Because if you have a lead in the atrium, which is now in AFib acting, it's driving at a rate of 300 to 600 times in a minute, then it's going to cause a lot of confusion for the pacemaker and will be ineffective. And in the end, the patient will suffer. So then for AFib, your aim is to pace the ventricle while ignoring atrial activity. Okay. So now we need to look at the pacemaker timing cycles, because when you put a pacemaker in, there are certain things you need to do to make sure that it's functioning and giving you the kind of physiological outputs that you are seeking to have. And you need to remember that pacemakers don't have minds of their own. And so they only do what they are instructed to do based on the timing you give them. So as the saying goes, garbage in, garbage out. If you don't program your pacemaker the way it should, or the way you want it to work, it's not going to give you the output you want, and the patient is going to suffer for it. So first, others will call it the lower rate limit. And this is the set time at which the pacemaker spikes will be fired. And so and if you're doing single chamber pacing and you're then once that rate is elapsed, it will fire a pacemaker spike. Now in asynchronous pacing, the problem is that you are not really sensing what's going on. You are just pacing at regular intervals. So then there's a chance that you may deliver the pacemaker spike on the T wave, and then you sort of have what you have in an R on C phenomenon with ventricular ectopics, and that can degenerate into VFib. So in order to prevent this kind of thing from happening, there's a ventricular refractory period, which is the period where the ventricle is in a sense blind. So then, the ventricular lead. So after it's delivered the spike, the pacemaker does not see other electrical activity, because once it sees electrical activity, it may end up delivering another charge, and that can lead to arrhythmias. I think yes. Okay, so I think this would explain it better. So over here, sorry, I just want to confirm. Can I still be heard?
Yes, you can be heard.
Yes.
Okay, thank you. Yes, so so this is the lower rate interval I was talking of. So you have set the rate. When it comes to pacing, it's set in milliseconds, not in beats per minute. And if you want to translate it into beats per minute, then it's 60,000 divided by the milliseconds. So for example, if you set it at a rate of 1,000 milliseconds, then that comes to 60 beats per minute. If it's 600 milliseconds, that's 100 beats per minute. So over here, the lower rate interval has been set. Now, what happens in the lower rate interval is that if you have your pacemaker and it fires an impulse, the timer starts. So it is going to, let's use 1,000 milliseconds for this. So it's going to 1,000 milliseconds. If it doesn't sense any activity, then it will release another spike and then pace. Over here, this will be explained when we start talking about the dual chamber timing. But over here as well, you see that you have the ventricular timer starting from here, and it goes all the way to the end of the lower rate interval. So that is what determines the base rate of the pacemaker. And there are times when the lead will identify its own spike. So even though it has spiked over here, it may recognize other components of the QRS or T wave and recognize it as intrinsic activity. So it will sense it and act based on that. So to prevent that, there's a refractory period here, ventricular refractory period, that is programmed so that at this point, the pacemaker does not see what is going on. This is to prevent it from recognizing its own activity and acting based on that. Okay. Then we have the open interval, which is otherwise called the alert period. And that is equal to the lower rate interval minus the ventricular repolarization, refractory period. So here you have the lower rate interval and you have the refractory period. Yeah, as I mentioned over here, the ventricular lead can't see anything. So from this point, from the end of the ventricular refractory period up until this point, this is where the ventricular lead can see. So if, for example, an atrial, so if for example, a ventricular complex is sensed within this period, then it will not at all reset the timer. However, if not, then it's going to go all the way to the end of the rarity interval before it fires. Now, when it comes to dual chamber pacing, as I said, it's supposed to mimic the natural activity of the heart. So then you have, normally in the heart, you have a P wave, you have a PR interval before the QRS. So similarly, once there's a pace, once there's atrial activity, whether paced or sensed, it begins a clock which is called the atrioventricular interval or the AV interval, AVI. This is the equivalent of the PR interval. Now, whether it is a sensed A wave or a paced a sensed P wave or a paced P wave, it triggers the AVI. But usually with a sensed P wave, it's programmed to a shorter duration. So coming back to this diagram, over here, you realize that it has paced over here the atrium. So it has started the AVI. So in a DDD pacemaker, you realize that the response to sensing is both inhibition and triggering. So over here, because it has paced, it has triggered the AVI leading to ventricular depolarization. So that is the triggering. So then you have the AVI. Now AVI has elapsed, so you have ventricular depolarization. It goes on another pacing, AVI, ventricular depolarization. But here it senses the atrial activity, which is an intrinsic P wave. So it inhibits the atrial lead, so the atrial lead doesn't pace, but it triggers the AVI, which leads to ventricular depolarization. So this is what is meant by the third D, which is both triggered and inhibition when it comes to the DDD patient. So that's just the same thing that's being depicted over here. All right. Then there's a concept called there's another time called the post-ventricular atrial refractory period. Now, after the ventricle contracts, or after the ventricular lead fires, after the ventricular spike, the atrium still can still pick up activity within that complex. Now, we know that when the ventricle paces, just like how you would have in a junctional rhythm, you can have retrograde flow of current back into the atrium. And if that goes into the atrium, then what's going to happen is the atrial lead will now sense that as intrinsic activity and trigger the timer for the AVI. Then you have another ventricular impulse, and then it will go retrogradely, and the atrium will sense it. Now, when this happens, it leads to a phenomenon called pacemaker-mediated tachycardia, PMT. And we want to prevent this. So the post-ventricular atrial refractory period, what happens in this time is that the atrium can see what is going on, but it cannot react to it. So it is programmed such that it can see it, it can sense it, but it doesn't trigger any response to it. And the reason this is important is that sometimes when there are other atrial arrhythmias, they may occur within that period. And if you satisfy that it is totally blind to activity, then when you interrogate the pacemaker, it's not going to report atrial flutter that occurs in that period, atrial fibrillation, and that can give you a whole lot of problems with the patient. So basically, the post-ventricular atrial refractory period, the aim is to prevent pacemaker-mediated tachycardia from occurring. Then the total atrial refractory period is the AVI plus the PVAP. That is the total atrial refractory period. And I think we'll talk a bit more about it in a few more slides. So this is just describing what happens with the pacemaker-mediated tachycardia. So you see here, there was a ventricular pace, and this was a retrograde P wave. The atrium sensed it. So it started the AVI, which then fired another ventricular impulse. Retrograde P wave, atrium sensed it. And so over here you have the tachycardia. Now, at this point, the PVAP is in place. So the atrium picked the retrograde P wave all right, but because it's occurred within the PVAP, the atrial lead has been told it's within PVAP, do nothing, just look at it and keep quiet. So then it just observes and then it moves on till the next pacer spike as it's supposed to be. So this is the importance of the PVAP. So again, to this diagram, so atrial pace, AVI, ventricular pace, the lower rate interval starts. PVAP is going to prevent retrograde conduction, or rather, it's going to prevent atrial activity in response to the retrograde conduction. Now, over here, you realize that the atrium sense or the intrinsic atrial activity occurred before the lower rate interval elapsed. So you realize that this lower rate interval is shorter. And if you had gone to the end, this is where it would have ended. So because now at this point it has fired, the clock restarts, it resets. And then it comes all the way. There was intrinsic ventricular activity over here, which was sensed. So it stopped the clock and then restarted it. Then there was a ventricular ectopic. So it also stopped the clock and then restarted. This one went all the way through to the end. So this is how the timing cycles interact in order to ensure that as much as possible, the pacemaker mimics the activity of the real heart. Now, when there's when you have the pacemaker set, you remember there was the total atrial refractory period, otherwise called the TAP. And what happens is that when you have a patient who is at rest, it's really not a problem. But when you have a patient who is active and therefore the atrial rate is higher, then you realize that the interval between the E waves tends to shorten because it's coming at a faster rate. But you remember that during the PVAP, the lead can sense, but it does not act. So what happens is that it speeds up to a point that eventually the atrial impulse falls within the PVAP. And once it falls within the PVAP, the pacemaker can't respond to it. So then nothing happens, and then you have this actual atrial sense. So in effect, what happens is that you have atrial sense before ventricular pace, and that will go on, and this gives you a 2-to-1 pacemaker block. The problem with this is that imagine you are running and your heart is at 110 beats per minute, 115. You hit 120 beats per minute, and all of a sudden your pacemaker drops you down to 60 beats per minute just because it cannot send this one that's occurred within the PVAP. So in the end, what happens is that it causes the 2-to-1 block, which can have profound symptoms as far as the patient is concerned. So a way of going about this is by inducing a pacemaker Wenke back. And to do that, the pacemaker upper rate is set to be lower than the pacemaker's 2-to-1 rate. And when this happens, then it causes a more gradual change in the heart's rate. And we know that Wenke back compared to the 2-to-1 AB block is much more favorable. So then this ends up protecting the patient. And the 2-to-1 interval of the points at which 2-to-1 block occurs in a pacemaker is given by 60,000 divided by the TAP, that's the total atrial refractory period. So now we are going to look at certain problems with pacemakers and how to overcome them. So there's a phenomenon called crosstalk, and crosstalk just means that The ventricle is seeing what's going on in the atrium is seeing what's going on in the ventricle. So they are talking across basically. Now over here, you realize that here there's atrial sensing. It sends intrinsic activity over here, and the ventricle has paced. Here, atrium has sensed, ventricle has paced. Now over here, the atrium paced, it didn't sense, but the ventricle sensed this atrial pace as its intrinsic activity. So because it is programmed to inhibit once it senses itself, it's inhibited its output, so there's no ventricular pace. Then over here again, atrium paced, ventricle sensed, so it didn't act. Atrium paced, ventricle sensed, didn't act, and the same happened here. Realize that for this entire period, there's no QRS. And so this patient is an asystole at this point because the ventricle is sensing the atrial spike. Now, crosstalk only occurs with atrial pacing, not atrial sensing. It was sensing and there was nothing wrong. But once the atrial pacemaker spike came in, that is when the ventricular lead started seeing it and then the crosstalk occurred. So this is an example of oversensing because there is no ventricular activity, but it is still sensing something going on in the ventricle. Sorry, it's sensing what's going on in the atrium as it's going on in the ventricle and refusing to pace. So this patient will have asystole and probably go into cardiac arrest. So this is what happens when you oversense. When you oversense, you end up under pacing. In order to prevent this, another time is introduced. Now there's a period called the post-atrial ventricular blanking. So that is over here. So you see after the paced atrial impulse, it initiates the post-atrial ventricular blanking timer. During this time, the ventricular lead is blind. It can't see anything. So once this time is there, then the ventricular lead will not be able to see the atrial spike. So then it eliminates the crosstalk. But this period is just a few seconds, 10 to 60 seconds. So okay, again over here you can see that because of the post-atrial ventricular blank, the ventricle does not perceive this, so it cannot work, and then it paces at its usual interval, which is after the AVI. But there are times that there may be impulses that are sensed outside the ventricular blanking period. And for this reason, there's another time setting. So we come down here. So you see there's a ventricular blanking down here. And you realize that it went all the way to the end of the AVI, and then it's discharged. Now you have the atrial pace and there's blanking. But after the blanking, this other thing has occurred here. And so this can trigger ventricular activity. And if it is too short an interval, then it causes a problem. So there's another time which is called the ventricular safety pacing window. And what this time does is that it tells the pacemaker that, okay, if you sense, it tells the ventricular that if you sense activity within this period, you wait for this period to elapse and then fire. So whether it senses it here or here or here, it's going to wait for the end of the safety period before it actually fires the QRS, so that it still maintains the timing as it should and still maintains physiological function. And then just as we have a post-atrial ventricular blanking, we have a post-ventricular atrial blanking, so that the atrium also doesn't, through crosstalk, look at ventricular activity and then restart its own cycle. With undersensing, there's an intrinsic beat, but the pacemaker does not see it. So here you have a paced beat. There's another paced beat here. Here you realize this is a narrow complex, so this is intrinsic rhythm. So ideally, the pacemaker should have sensed this and withheld its charge, but you realize that it has discharged a spike over here. Then there's more intrinsic activity. So as you saw in one of the earlier diagrams, this one, when it senses, the timers are to start afresh. But over here, it is not sensing because the timer, you can see that the timer is not starting afresh. The interval is not the same as the interval that you see earlier. Then here you have a paced one. Here, sinus, it doesn't sense it, it's fired. So this is what we call undersensing. It is not seeing what it should see. So when you undersense, you overpace. And when you oversense, you underpace. And so oversensing can lead to cause underpacing, can lead to asystole, and can also lead to misclassifying tachyarrhythmias. Then undersensing also causes overpacing, and this could also induce arrhythmias. So what do you do in these situations? Interrogate the pacemaker and then review the settings. Check the timings, make sure that they are as you intend for them to be. And then also check the impedance, which is the overall resistance to flow. And with the impedance, you're interested in the trend. So is the impedance the same as it was? Has it gone higher than it was? Was it a slow rise? Was it a sudden rise? These all have implications. So for example, if the impedance is lower than it was, it could be that there's a leak in the insulator. And so there's less resistance to flow. Or there's a break in the conductor that can make it high. Or if it's rising slowly, it can be that over time, the area where the pacemaker lead is getting fibrotic or it's getting calcified. And so gradually there's increasing resistance. Or it could be that you started off with a certain impedance level and all of a sudden it's dropped. So it could be that this is more when you're implanting the pacemaker. It can be that you've punctured the tissue and gone into the ventricular cavity. And so as a result of that, you have a sudden drop in impedance. Then you also check the sensing and then the pacing thresholds. And then you have to do an X-ray, AP and lateral, to assess the leads and make sure that the contour doesn't show a break and then it's still inserted where it's supposed to be. So to summarize, I know there's been a lot of technical terms and times that sounded very confusing, but just to go over it, atrium paces, AV, I or AV delay starts, ventricle paces. After the atrium paces, in order to prevent crosstalk, there's ventricular blanking so that the ventricular lead cannot see what is going on in the ventricular lead and the atrial lead and then interpret it as its own activity. Then again, after the ventricle, we have the postventricular atrial blanking. So for the same reason you have the ventricular blanking, we don't want the atrium to sense this through crosstalk and then start its own cycle again. We have the PVAP, which is supposed to prevent the effects of retrograde conduction back into the atrium, which will result in pacemaker-mediated tachycardia. And then the ventricular refractory period, which is a period where the ventricle will just sit and then observe but cannot be depolarized again. Then the VA interval is the derived interval from the end of the ventricular depolarization from the beginning of the ventricular depolarization to the next atrial depolarization. That's the VA interval, ventricular atrial interval. And then you have the lower rate limit, which sets the base rate at which the heart contracts. And the upper rate limit, which is important in initiating the Wenke back to prevent the pacemaker-induced 2-to-1 block. So thank you very much for listening. And if there are any questions, I'll attempt to answer them because it's also quite technical for me too. Thank you very much.
Yes, thank you so much, Dr. Samuel, for trying to simplify this complex topic. I'll open the floor. I'm sure we have a lot of questions, clarifications that we want to make. I'll open the floor for any questions or clarification, you can unmute and ask your questions. So in the chat box, a lot of thanks. Dr. Kalamama is saying great job, Doc. And Dr. Omokorade is saying thank you for the presentation.
Thank you very much.
Yeah. I don't know. I was thinking, how does the rate modulation help in preventing the bradycardia and pacemaker-induced bradycardia in exercise that you are talking about? How would the rate modulation help to prevent that?
So a lot of the more modern pacemakers are fitted with accelerometers and other electronic components that monitor what's it called, the diaphragmatic activity, breathing rate, and once they pick that, then they automatically adjust the AVI and then the PVAP on their own so that it allows you to exercise. So then with those ones, I'm not 100% certain, but because they are able to modify the AVI and PVAP, which in effect alters the total atrial refractory period, it is able to handle more rapid P waves and would afford you much more exercise. However, I believe at a certain point, it will still predispose you to having the 2-to-1 block, but it will be better than those who are not rate modulated.
Okay, thank you very much. Chief
Okay,
hosting the excellent detailed presentation, simplified a lot of complex concepts. Thank you, sir. Okay, you can go ahead, Florence.
okay, thank you so much, Dr. Katie Asamoah. Okay, so this is just a clinical scenario. Okay, we know we have indications for pacing and all. So, okay, I know one of the indications is where we have a complete heart block, a complete AV block, and then with an ejection fraction less than 40%, and then the patient is symptomatic. So I have an elderly patient who has a complete heart block, and then her ejection fraction is about 38%, but this lady is asymptomatic. Do we need to still pace this lady? She's no syncopal attacks, no breathlessness. Like, I think, okay, basically what she came in for was palpitations or so. She presented with palpitations, and then we did a holistic workup for her, and then we realized that she actually had a complete heart block, and then her ejection fraction was 38. But aside the palpitations, she doesn't really have any other complaint. Do we need to pace? Then secondly, there's a clinical scenario my boss pointed out to me, that there was a patient with a complete heart block, and what they basically did for this patient was just to give lipid lowering medications, and they also added atropine, and then it corrected it. When they repeated it after some months, I don't know whether it was no more a complete. I can't remember the clinical scenario. So is it possible that all of these can happen? Because I saw your like, if you have a patient with a complete heart block, you actually have to check for secondary causes like ischemia, like dyslipidemia, like hyperkalemia. So does it mean that a patient who has maybe probably hyperkalemia, then you correct the hyperkalemia, the patient would not really need a pacemaker? Or if this patient has some form of dyslipidemia and then you give lipid lowering medications, this patient will not really meet the criteria for pacing? Because I've seen quite a number of patients with a complete AV block. Do we need to go ahead to pace with all these clinical scenarios? For example, the woman I just pointed out to you, whose ejection fraction is 38, and then she has a complete heart block, and then we presented with just palpitations. So I don't know, please, what's your take on it? Do you think this patient would need um, a pacing.
Okay, thank you very much. So I think what you brought up is a major concern, especially in a part of the world where pacemakers cost an arm and a leg. So what the guidelines recommend is that generally, once you have a complete AV block, it's an infranodal rhythm, and infranodal rhythms are generally not very reliable in the sense that they can easily um, result in cerebral hypoperfusion. They can lead to um, asystole and cause death. So generally, the recommendation is if you have a higher degree AV block, which is 2 to 1 and above, so maybe 2 and above, or a third degree AV block, you should aim to pace this patient because this is an unreliable rhythm. Um, but I think another thing is the broader the complex, the greater the risk because it means the lower the escape rhythm. So there are some people who may have complete AV block, but their mean heart rate is, let's say, somewhere around 48, 46. And this is probably because they have an escape rhythm that is more around the kiss. It's more of a junctional kind of escape rhythm. So those ones are much more stable because they are narrower. Those ones you could probably buy yourself some time and you could probably observe, especially if they can't afford. But those who have broad complexes, they would tend to have lower heart rates like 28, 30, 32. They are also the ones who are more notorious to have more notorious for having suicidal attacks. So the long and short of it is the recommendation is if you have a 2 to 1 AV block or worse, pace. But on the ground, we are not able to do that for everyone. So if I'm no authority, but if I were to prioritize, I prioritize those with broader complexes than those with narrower complexes. To your second question, yes, there are secondary causes that once you eliminate, you may not need to pace. There was a time last year I was on call. There was a patient from orthopedics who had a complete heart block. So they sent a cardiology consult and we went to review this patient and she was an AKI with a potassium of 7.3. We said, no, we're not going to recommend pacing. They should correct the hyperkalemia, sort out her AKI, and then we'll review afterward. Potassium came down to 4.3, renal function improved, shot back in sinus rhythm. So then she wasn't offered a pacing at all. There are also those who may have sort of like an intermittent AV block. So these are people who one may have ischemia, and so it's like there are times when because of ischemia they are in the AV block. There are times when there's some okay perfusion, so then they are not in a permanent state of AV block. There are also some who may have some degeneration, but it's not sort of completely the congestion is not completely degenerated. So then these people may still have times when they have a normal sinus kind of rhythm in times that they're going to AV block. So those who have the intermittent ones, you still have to see if you can find a secondary cause. But if you can't, I think it will be a better option to still pay these people because you don't know when they're going to go into that AV block rhythm. And again, those who have third degree AV block and have heart failure, especially with a low ejection fraction, the recommendation is don't just pace, but do a CRT. Because the CRT will help the heart failure and will also pace to correct the arrhythmia. Thank you.
Thank you so much. Thank you. I appreciate it.
You're welcome.
Hello, Chief.
Yes, sir.
Yeah, there's an ECG that I sent to the group now. I was actually called for that patient, 74-year-old nurse, a non-hypertensive for so long with good drug compliance. Just recently, they said he's been having body weakness, no palpitation, no syncope or chest pain. So they said the pulse was 35. I told them to count the artery. The artery was 37 thereabouts. So I just insisted, okay, and where? So in retrospect, I now noticed it's been on. They said it's been on attend a lot, so which I told also them to stop. But I now asked them to do an ECG. Of course, they did an ECG. The ECG, the rate there was about I think 43 or 47. So I wasn't sure, though. Body weakness, there was no. So they had. I was in the dilemma whether to ask them to give atropine. The BP was fine. There was no issue. Apart from the weakness. So I told them to do some other things, but because of the financial, they couldn't do it. But I was a bit skeptical about the atropine because, um, but I sent the ECG to the group now.
Yes. So I've seen the ECG.
So what's your take on?
I think it's a bit tricky, but okay. So I think what's on the ECG is this patient has a ventricular premature complex bigeminy.
Yeah.
Yes, and we know that when there is an ectopic, it sort of resets the SA node. So this bradycardia may actually just be, in a sense, functional because of the ectopics, and not that there's an actual AV nodal disease per se. It may just be because the ectopics are resetting the conduction system, and so you have the compensatory pause. However, given her age, I see that it's a female, so given her age of 74, I will think that if possible, I don't think there will be harm in doing a trial of the atropine, even if it's a single dose. But I think if the ectopics can be tackled, then it will give a better appreciation of the rate and how to proceed. In terms of tackling it, I'm not sure whether with this anyone will be bold enough to do with this rate, anyone will be bold enough to do the beta blocker to try and then suppress the ectopics or amiodarone, because that would also cause bradycardia. So I'm really not sure exactly what will be beneficial here. But I think if there is a way to eliminate these ectopics, then it will give a better appreciation. I think another thing that can be done is you could probably do a Holter ECG,
Okay.
and then with that you get to see what the 24-hour heart rate is like, and that will probably inform you or give you some more confidence on whether or not you can actually try a beta blocker. If you do it and you realize that the average heart rate is 70 or something, then at least you can probably do bisoprolol 1.5 or 1.25 or 2.5 or something. But if you do the Holter and the heart rate is 40, that kind of thing, then definitely there's an issue. And in patients like this, you may have to pace and treat the arrhythmia as you would do for a tachybrady kind of thing. Because if you just give a beta blocker or amiodarone to try and suppress the ectopic, it may push the bradycardia further down, and that may kill the patient. So then you pace so that you have your minimum rate, and then you can go all out with your antiarrhythmic therapy. I think that those are the things that you can consider, in my opinion. Thank you.
Okay, thank you.
You're welcome.
Yeah.
Thank you.
Hello.
Maybe I'll leave to maybe Dr. Conte and my other chiefs. They can, of course, also comment on.
Yeah. Hello. Yes. Yeah. As Dr. Samuel mentioned, so those are some of the options that you have. But another thing that you can consider, even though it's not available to us, is that when you look at the rhythm, you see that it is the PVC is monofocal. See, it's the same right to it coming from one, that's telling you that it's coming from one specific source in the ventricle. So those ones that are easily amenable to ablation, you can actually isolate the site where it's coming from and ablate it and actually stop the premature ventricular contraction. And if when you ablate the SA nodal rate is above 60, then you don't need to pace the patient taking.
Thank you, Chief.
All right.
Okay, let me
Any
just
other
comment.
question from the colleagues before we take contributions from our chiefs? Okay, so in the absence of further questions from colleagues, I'll hand over to Chief Okopi to take comments from our chiefs and then close this session.
All right, thank you so much, Dr. Conte, for that beautiful coordinating, and Dr. Asamoah. It's nice to hear your voice. I never knew you were in the group. How are you doing? It's been long. We need to see
I'm
you
fine,
more
thank
often.
So I'm actually not in the group.
Oh, you're
So
not in
Dr.
the group?
Conte, no, Dr. Conte just asked me to deliver this presentation. Yes, but
Okay.
I'm actually not in the group.
I've been trying
Okay,
to drag him in.
I've
I've been
spoken with
trying
him
to
on
drag
LinkedIn.
him.
Oh, lovely.
He's been dodging
Okay,
me. He's been
Doctor.
dodging me.
Okay, Doctor Asamoah. By the virtue of the power vested upon me, I therefore henceforth, going forward, untoward, add you to the group.
Thank you.
we would really need you to be in the group, because I don't know, probably because of my also personalized studies on this particular concept, but you did a lot of justice to it. You made it very simple.
Thank
And
you, man.
those going for exams, I still feel they will need your help in intracardiac ECG. Some concepts are there to be explained. Those hemodynamics and co. We need your help. We need your help.
Yes.
So after this meeting, I'm going to add you to the group, and please, on behalf of everybody listening to me, that you should please help us. We are speaking like the Macedonian. Come and help us.
Yes, sir.
Thank you so much. With respect to the ECG, I saw the page PVCs by Germany. Did you check, Dr. Ayodeji, if there is a previous ECG of this woman and then this now, and if there's a possible underlying cause where we're having PVCs now in by Germany?
No, she actually did. They sent one to me, which was done in May. It was fine. The rate was. I didn't see the rate then was 60. But I just insisted
Okay.
this woman need to have an ECG today because it was that one they sent to me. I said, that's in May. That's a long time.
Okay. So could there be a possibility, apart from what they have said? I agree with everything as Samoa said, everything that Conte said. Looking at the ECG, if you could take a look at a possible, is there an ischemic focus? Is there something that is triggering this PVC that can be taken care of in a short term? And in between, I will actually go with what Asamoah said. Since we don't have an ablative procedure, a low dose beta blocker to take care of the PVC to allow the innate reading to be more pronounced, and then see how it goes. I will not be afraid of
Okay,
doing that.
just like you said, Chief. Maybe after the
Mm,
altar, maybe after the
mm,
altar ECG, of course, we can go that
mm.
route. So that if see maybe he's having the tachy, or maybe he's an alternating, maybe tachybrady, we can do that low dose, maybe after the altar. Or what do you think, Chief?
Yes, yes. Well, you can even hang the altar tonight and then see it. Within the next 24 hours and then examine. But I still think you should watch out for what could be causing now the PVC, since the previous ECG was actually something normal. And then if you can do an echocardiography, check the pericarditis or something.
I also requested for it to be done and all that.
Okay, that would be nice. All right, thank you so much, Dr. Samoa. That's very, very excellent presentation. I actually enjoyed it. I was so happy to have understood so many things that were quite cloudy in my mind. I don't know if we have any of our chiefs. Alison is not on ground, and we don't have Adeyanju. We don't have any other person. All right. I think is there anybody with particular pressing question with your practice or anything that you would want us to clear before we close the class? All right, there's nobody. Thank you so much, Dr. Samoa, for a beautiful presentation. I actually enjoyed it. I don't have questions. I will just plead on behalf of the class. If we add you tonight, this night, I'm adding you immediately. And then if you can please come up to help us before the exam in a couple of concepts that we need help on this ground. But before that, thank you again. Thank you so much. You're
Thank you
actually
very much,
good in
sir.
what you do. Thank you so much. Dr.
Thank you, sir.
Felix, thank you. I can see you, Dr. Felix, Dr. Eugene, and a couple of our friends over there. We're excited to have you. Dr. Conte, over to you. Thank you, sir.
Yeah, thank you very much, Chief Okope, as always. Dr. Kalamama, please, if there are any announcements before we close.
Okay, not at all, not at all. Thank you.
All right. Okay, so today is Friday. I don't know if we should thank God it's Friday but anyway, continue.
Please, Dr. Conte, send me his number, please. Send me Dr. Samuel's numbers. Let me add him immediately.
Okay, I will. So we shall continue on Monday. Come prepared. Right. Monday we would have Dr. Awindago continue the trend on device therapy. So he would take us on CRT and ICD. So let's all read around that and come for a very fruitful discussion. Okay, so that's all for today. Have a wonderful weekend, everyone.